in BMPR2 gene normally inhibits vascular smooth muscle proliferation. So BMPR is basically a good thing, right? So it will inhibit the vascular smooth muscle over proliferation. But what happens here? There is inactivation. Okay, I'm talking about pulmonary arterial hypertension. Remember that. So in BMPR, it is a autosomal dominant. Remember one thing. And the poor prognosis, pulmonary vasculizer endothelial dysfunction result in increased vasoconstrictors, for example, endothelin, and decreased vasodilator, that is nitric oxide and prostacyclins. So other causes include amphetamine, cocaine, connective tissue disease, HIV infection, portal hypertension, congenital heart disease, and schistosomiasis. So all these can cause pulmonary artery hypertension. Okay, now talking about left heart disease, causes include systolic and diastolic dysfunction and valvular disease. Okay, this could also cause pulmonary hypertension. And apart from that, there is lung disease or hypoxia. Remember, the hypoxia can cause vasoconstriction. So yes, destruction of lung parenchyma, example COPD, or lung inflammation fibrosis, example in interstitial lung disease. There will be hypoxemic vasoconstrictor, example obstructive sleep apnea living in high altitude. Chronic thromboemboli, recurrent microthrombi, decrease in cross-sectional area of the pulmonary vascular bed. Okay. And multifactorial, there could be cause include, in multifactorial, the cause include hematological, systemic, okay, metabolic disorder, along with compression of pulmonary vasculature by a tumor. Okay, remember these things. So any lung disease, for example COPD, interstitial lung disease, or obstructive sleep apnea or high altitude can cause pulmonary hypertension. Now one thing that I have added here is in neuromuscular weakness, okay, stimulation of hypoglossal nerve using an implantable nerve stimulation causes the tongue to move forward slightly, increasing the epidiameter at the airway. Studies with these devices have shown reduction in the number of obstructive events during sleep. So stimulation of hypoglossal nerve is very important that you need to remember here. Okay. All right, these things we have already talked, so don't worry about this. Next please. Now talking about the lung physical findings in selective disease. This is not that difficult, okay, if you have done your clinical rotation well. See what happens in pleural effusion. Obviously there will be decrease in breath sound. So decrease in breath sound is observed in almost all the lung diseases except the consolidation, where bronchial breath sound is heard, associated with egophony and whispered bacterioliquid. Okay, percussion, there will be dull in pleural effusion and atelectasis. Only thing that can cause hyperresonant is the okay, simple pneumothorax and tensor pneumothorax. One thing I would like to add is there is woody dullness in the consolidation, but it is stony dullness in the case of pleural effusion. Okay, remember that. Now talking about fremitus, fremitus is increased only in the case of consolidation. Remember that. Okay, only in the case of consolidation the fremitus will increase, otherwise it will decrease in almost all cases. Now tracheal deviation, none if small, okay, pleural effusion, away from the side of lesion if the pleural effusion is massive, and that is logical. Atelectasis towards the side of lesion, right? So there is nothing on the atelectasis side, I mean to say the lung parenchyma has been collapsed, so that's why the deviation will be towards that side, okay, towards the empty side. Now talking about simple pneumothorax, there will be non-deviation. Tensor pneumothorax, always from the side of lesion, always away from the side of lesion, and that is logical again because the air is pushing the trachea towards the opposite sides, okay, and there is no deviation in the tracheal deviation in the case of consolidation, lobar pneumonia, or pulmonary edema. Now talking about the atelectasis, there are different kind of atelectasis. Basically atelectasis is another term for alveolar collapse, which can be due to multiple etiologies. As I said, obstructive airway obstruction prevents new air from reaching the distal airways. Old air is resorbed, example foreign body, mucus plug, tumor, okay, anything can cause obstructive alveolar collapse. Compressive, external compression on lung lung decreases lung volume. Example, space occupying lesion, pleural effusion. Contraction, cicatrization. Okay, cicatrization, scarring of lung parenchyma that distorts the alveoli. Example in sarcoidosis. So sarcoidosis can lead to the contraction atelectasis. Remember that. Okay, this can be a question, possible question. Adhesive due to lack of surfactant. So if there is lack of surfactant, for example in NRDS, that can be adhesive type. So contraction, there is scarring. Okay, adhesion, there is lack of surfactant, and compressive is because of some space occupying lesion, and obstructive is because of obviously foreign body, and it could be because of mucus plugging, as in, yes, very good, asthma. Okay, asthma, there is risk of mucus plug and tumor. Okay, now next, let's talk about the pleural effusion, right? Pleural effusion, excess accumulation of fluid between the pleural layers. Restrictive lung expansion during the inspiration can be treated with thoracocentesis to remove or reduce the fluid, right? So it could be transudative, exudative, or lymphatic. Transudative is decrease in protein content due to hydrostatic pressure, heart failure, or decrease in oncotic pressure, example nephrotic syndrome or cirrhosis. Exudate, and there is increased protein content, cloudy, due to malignancy, pneumonia, collagen vascular disease, trauma. Occurs in states of increased vascular permeability, must be drained due to risk of infection. Lymphatic, also known as xylothorax, due to thoracic duct injury from trauma or malignancy. Milky appearing fluid is because of the rich in triglycerides. So remember, those white thing is due to triglycerides, right? Okay, now here I have in a very short way tried to depict the different images showing how thoracic duct progress. So you can see this is lumbar lymph, intestinal lymph. All these lumbar and intestinal lymph will drain into the cisterna chyli, and there can be descending thoracic lymph trunk that will also drain here in the thoracic duct, and all this will follow this path, and it will open into the left subclavian vessel, right? This thing. And on the right subclavian trunk, you can see this is right jugular trunk, right lymphatic duct, and right bronchomediastinal lymph node. Lymph will be draining in the right side on the right subclavian trunk. Okay, remember this. Next page. Now let's talk about the thing called pneumothorax. Okay, so pneumothorax, you can see pneumothorax is accumulation of air in pleural space. Dyspnea, uneven chest expansion. Okay, so obviously there is uneven chest expansion. This is very, very, very important again. And there can be chest pain, decrease in tactile fremitus, hyperresonance, and diminished breath sounds, all on the affected side. Now think about it. Okay, so there is decreased tactile fremitus, hyperresonance because it is filled with air, so there will be hyperresonance, and diminished breath sound, all on the affected side. Okay, so chest pain is basically on the affected side again, because more negative I was talking about primary spontaneous pneumothorax now. Okay, so due to rupture of apical subpleural bleb or cyst, occurs most often in the tall, thin young male and smokers. They will typically tell you there was a basketball player or a tall man, like that kind of history. So be very careful about that. And remember, it is because more negative intrapleural pressure in the lung apices in that if the man is tall. Okay, so there is more negative intrapleural pressure. Now think about it. If there is more negative intrapleural pressure, it will try to, okay, it will tend to rupture the apical subpleural bleb by trying to sucking it. Okay, because there is more negative intrapleural pressure, so there will be sucking effect. Okay, trying to absorb those air, and there will be rupture of the apical subpleural bleb. So this is why tall people will have spontaneous pneumothorax. Now talking about secondary spontaneous pneumothorax, could be due to diseased lung, for example bulla in emphysema or infection. Mechanical ventilation with the use of high pressure, for example barotrauma. Okay, so barotrauma can also lead to the secondary spontaneous pneumothorax. So could be a disease of emphysema, for example bulla in emphysema, or could be mechanical ventilation with the use. So anything other than the other than itself. Okay, so if it is because of the underlying lung disease, it is again secondary. If it is because of some procedure, for example high pressure ventilation, that is again secondary. Now talking about traumatic pneumothorax, as the name suggests, it is because of the blunt trauma, for example rib fracture, penetrating gunshot, or iatrogenic, for example central line placement. All of these can cause traumatic pneumothorax. Lung biopsy, barotrauma due to mechanical ventilation, okay, or trauma. Anything that is causing trauma, okay, remember that. So that is traumatic pneumothorax. Now last thing is the tension pneumothorax. Okay, tension pneumothorax is because of the can be from any of the event, but what happens here is that air enters the pleural space, but sad news is that it cannot exit it. Okay, so there is increasing trapped air leading to tension pneumothorax. Trachea deviates away from the affected lung, may lead to increased intrathoracic pressure, mediastinal displacement, kinking of the inferior vena cava, venous return, and decreased cardiac output. Needs immediate needle decompression and chest tube placement. Remember that. So there can be sudden chest pain, unilateral. One side of the chest moves during respiration. Now, one thing I have written here is the one concept. Okay, 100% oxygen displaces nitrogen from the capillary blood. Okay, 100% increases the gradient for the nitrogen reabsorption from the pleural fluid. Chest tube, if you put the chest tube large for the only for the large pneumothorax. Okay, got it? So if there is, if you are giving 100% oxygen, what will happen? If there is 100% oxygen, if you are giving, so that will displace the nitrogen from the capillary blood, okay, and increases the gradient for nitrogen reabsorption from the pleural. So this is one of the technique how you can reabsorb the air inside the pleural space, okay, by giving 100% oxygen. Now one thing I have added is costochondritis. Okay, so if there is positive tenderness, then go with the costochondritis option. Okay, if there is tenderness present on chest palpation. Episodic chest pain that worsen with movement or changes in the position without warmth, swelling, erythema, or other cardiovascular pulmonary sign or syndrome. Okay, costoesternal syndrome. It is also known as costoesternal syndrome or anterior chest wall syndrome. Okay, now moving to the next page. Pneumonia. Now talking about pneumonia. Okay, so obviously what is the reason for mechanism of hypoxemia in pneumonia? So remember, it is because of the intrapulmonary shunting, again because the blood is coming from the right side and it is not getting any oxygen because of the consolidation and shunting into the left side of the heart without getting oxygen. So that is because of the intrapulmonary shunting. Now talking about different types of pneumonia. You can see here that the lobar pneumonia, streptoneumo is the most common, most frequently. Also Legionella, Klebsiella. Intra-alveolar exudate leads to the consolidation, may involve the entire lobe or the whole lung. Talking about the bronchopneumonia, again it could be because of strep pneumo, staph aureus, S. influenzae, or Klebsiella. Acute inflammation infiltrate from bronchioles into the adjacent alveoli. Okay, so from bronchioles into the adjacent alveoli. Patchy distribution involved more than one lobe. Okay, so bronchopneumonia, there will be patchy infiltration. Okay, whereas in the lobar pneumonia it will be entire lobe. Okay, so this is very important. Again, remember, in the lobar pneumonia only the alveoli was involved, but here in the bronchopneumonia the bronchioles are involved and adjacent alveoli is also involved, so there is only patchy. Okay, now talking about interstitial atypical pneumonia, atypical organism are involved as the name suggests. So mycoplasma, Chlamydophila pneumoniae or Chlamydophila psittaci. Okay, remember Chlamydophila psittaci is associated with parrot or bird exposure, right? So Legionella virus is respiratory syncytial virus, CMV, influenza, or adenovirus. Any of the viral infection can lead to the interstitial or atypical pneumonia. Remember that. And diffuse patchy inflammation. Okay, so there will be diffuse patchy inflammation localized to the interstitial area at alveolar walls. Chest x-rays show bilateral multifocal opacity, generally follows a more indolent course, so walking pneumonia. So basically the patient feature will be Externally it will be looking very fine, okay, so there will be less clinical features than the radiological features. Radiological features will be more exaggerated than the patient clinical features, okay, and it has a very indolent course. That's why it's called walking pneumonia, okay. Just imagine a patient is fine and walking all around, okay, but if you see the x-ray you will be terrified, okay. So this is a classic for atypical pneumonia. Now talking about cryptogenic organizing pneumonia, remember it is etiology is unknown. Secondary organizing pneumonia caused by chronic inflammatory disease, rheumatoid arthritis or medication side effects, for example, amiodarone, negative sputum and blood cultures, no response to antibiotics, okay. So basically, as you see, it is not caused by any of the bug, but basically follows a chronic inflammatory disease such as rheumatoid arthritis or some medication, for example, amiodarone. Okay, so this is cryptogenic organizing pneumonia. So you can see over here, formerly known as BOOP, okay, BOOP, bronchiolitis obliterans organizing pneumonia, non-infectious pneumonia characterized by inflammation of the bronchioles and surrounding structure. Now talking about the different stages, just remember 2 to 3, okay, 2 to 3. So first there will be 2 days, second there will be 2 days, and the third there will be 3 days, and finally after the 1 week, okay, there will be resolution. So first 2 days what happens, okay, so basically you see the lobar pneumonia is resolved in 8 days. So what are the things that happens in different stages? So the different stages are Korger, okay, I remembered it as Korger, CRGR, okay, CRGR, congestion, red hepatization, okay, I just want to write it over here, Korger. Okay, so congestion, red hepatization, gray hepatization, and resolution. So 1 to 2 days in congestion, what happens? As the name suggests, there will be congestion. As simple as that. Okay, red, purple, partial consolidation parenchyma exudates with mostly bacteria or edema. Red hepatization, there will be a red brown consolidated exudates with fibrin, bacteria, RBC, and WBC. Okay. So there will be full house, fibrin, bacteria, RBC, and WBC. And once the RBC is lysed, it becomes white. Now it is red. Now as the RBC is lysed, you see in the 5 to 7 days, uniformly gray exudative full of WBC and lysed RBC. Compare it with red hepatization where there was only RBC. Now the RBC is gone. That's why it is grayer than previously it was red hepatization, right? Fibrin is also there and WBC. Only difference is the lysed RBC. And you can also see the difference as there is full house WBC. You see exudate is full of WBC. There is no bacteria because all those bacteria has been phagocytosed or cleared. Okay, now in the resolution phase there will be enzyme digest the component of exudate. Okay, now I have added something about diagnosis of latent TB, so I want to add something. Okay, so what happens here is the identification of latent TB is crucial to infection control. Diagnosis is by tuberculin skin testing, subcutaneous injection, purified protein derivative PPD, 5 tuberculin units, that is 0.1 ml. After you inject that, what happens? Subcutaneous injection, you have to wait for 48 hours and measure the diameter of induration, not the erythema. If it is more than 15, okay, if it is more than 15, then it is healthy patient with more than 4 year old, healthy patient more than 4 year old with low likelihood. Okay, and if it is more than 10 mm, it is high risk individual, remember that. Okay, for example, silicosis, CKD, diabetes mellitus, IV drug abusers, homeless, prisoner, employees. If it is more than 5 mm, then it is positive for the HIV or immunocompromised, and if it is less than 5, then it is negative. Okay, false positive PPD test can be in the BCG vaccine, okay, or atypical mycobacteria. Positive PPD, you have to give isoniazid for 9 months, and further PPD testing not indicated because it will remain positive for the rest of his life. Okay, so this was all that you need to know about the diagnosis of latent TB. Next, So next chapter is cancer, and I think we will continue this on the next page, and we'll wrap up the respiratory pathology. Thank you for watching the video.